talk to you about the global burden of disease study. I'll start with a short introduction to what this massive public good is. And if you haven't heard of it, you should know after this talk. And I hope you'll go to our website and explore the massive amount of information on population health that we produce every year. But the main part of my talk is about a new development in this large project, and that is instead of looking at what is basically water under the bridge, what has already happened to people, what makes people die now, what makes people sick now, just saying, well, what are likely scenarios of what is going to happen into the future? So just to begin with, the global burden of disease is a systematic scientific effort to quantify the comparative magnitude of health loss from all major diseases, injuries, and risk factors in enormous amount of detail by age, sex, population, and over time. And our main goal here is to inform policymakers at every level, from local to global, with the best possible evidence on levels of disease, trends, and drivers of health outcomes, so that ultimately decisions can become more evidence-based. And importantly, the global burden of disease is a public good, and it echoes the previous speaker's theme of transparency, openness, sharing. Our current estimates cover 195 countries and territories for the time period from 1980 to the most recent year. And increasingly, we're breaking down populations into subnational units. We have a rule, an internal rule, that any population greater than 200 million must be broken down into subnational units. We're actually fearing that Nigeria and Pakistan will soon reach that limit because of the difficulties of making estimates in data-poor countries like that. And so China, India, US, Brazil, and Indonesia fall into that category currently. But through sometimes for opportunistic reasons and special contexts that we have with governments, we also make subnational estimates for a range of other countries, and a number are in the pipeline with the current set of estimates being produced for what we call GBD 2017, which will be published in September of this year. We currently have estimates for 333 diseases and injuries, almost 2,500 consequences of those diseases and injuries, and 84 risk factors or clusters of risk factors for which we make estimates. The whole time series is updated every year using new data, sometimes new methods, and we tend to publish in high-ranked medical and public health journals. We make policy reports, and importantly, we make all the data available, all the results available via online visualization tools. Just Google GBD visualization, and it will easily get you into the suite of tools. Traditionally, people have looked at metrics like prevalence, incidence, and death numbers and rates from disease. What the global burden of disease introduced was a way of cobbling them together and bringing them on an equal footing so that you can make meaningful comparisons. We translate deaths into years of life lost. We translate time spent with disability by waiting for severity also into a time metric. We cobble the two together, and then you have the DALY, or the disability-adjusted life year, or if you like, a summary measure of population health in a single number, a health-adjusted life expectancy. We concentrate on measuring population health loss. And for the mortality, we compare the age at death for every death against a reference life table of the best achieved mortality outcomes in any population currently, and that's a life table where at birth you have a life expectancy of 86.5 years. Importantly, we make a very strong statement that the same disability experienced by anyone, anywhere in the world should be valued equally. We don't give greater value to the same outcome depending on who the person is who has it. So that's an egalitarian approach. We currently have over 3,000 collaborators who actively participate in the study, provide data, critically examine results, co-author many of our papers, and this network is growing. We're hoping to cover some of the gray areas on this map. I actually went to see my nephew in Suriname in August, and this map is a little outdated because we got 2 people to sign up from the country of Suriname. Where do our data come from? We have 607 million death certificates for which we have information. We have 530 verbal autopsy studies, largely in parts of the world where there aren't any death certificates. Over 5,000 household surveys with microdata. Another 14,000 studies published in the peer-reviewed literature, and data extracted on maybe incidence or prevalence, case fatality rates, severity levels, etc. And we increasingly make use of administrative data sources, national accounts, health service encounter data, infectious disease case reports, claims data, survey reports. And we have the biggest repository of population health data, and it's called GHDX, and almost all our sources are available from there, with the exception of a small percentage of data that we receive from partners who say, you can have it for purposes of making estimates, but we don't want you to share it with anyone else. But even then, we try to convince the data custodians to be more transparent. Okay, now just taking the step onto forecasting. This has not yet been formally published, so I'm giving you a preview of what the ideas are and what we're looking at. Numbers may change a little bit, but the expectation is that a paper on this, a first paper, will be submitted in the first half of this year still, and coming out soon in the fall. Now, why would you do this? First of all, it's important to provide information on investment decisions that have long-run payoffs, such as where should you put your money for research and development? What sort of health professionals need training? What types of hospitals and other infrastructure needs to be built to adequately respond to the health problems in coming decades? Also, it will help to identify challenges that may become more important determinants of health loss in the future. Things like massive migration or urbanization, obesity, but the list is very long of what could be looked at. And this will give governments and other policymakers insights into what the implications are of health change for health and social protection systems. And of course, we'd like to then be able to identify and mitigate some of the risks. And with forecasting, you would hope that many of your forecasts will actually not happen, because you can do something about them to turn them into a better trajectory. So the objectives are that we generate first a baseline of what we think is a likely sort of trundling along of what has happened in the past, and then provide bounds of what a better scenario could be and a worse projection, and we forecast 25 years out for all individual outputs that the global burden of disease produces on a year-by-year basis until the most recent year. So we'll look at what are the trends in risk factors, but also important, what are the trends in important covariates? What's likely to happen with GDP? What's likely to happen with education? And other major covariates that help us make predictive models of health loss. And then, what happens with mortality by cause? What happens with morbidity? What happens with population? And what is the eventual impact on our summary measures, including DALYs? So once we have those scenarios, we can build on an infinite number of what-if scenarios. Example here, what if there are new vaccines? What if there's accelerated or stagnating progress in the development of new vaccines? What, under different scenarios of intervention scale-up, will happen? The better-worse scenarios are following the sort of practice in other industries where we take an 85 percentile better scenario and a 15 percentile worse scenario. But all sort of bespoke scenarios could be calculated once we have the overall framework set up. And I'm not saying a lot about methods, but an important part of the validation of these forecasts are out-of-sample predictive validity. Basically, you take the last n number of years out of your model, you fit the model on the years before that, and you look at how well does the model predict the years that you left out relative to what you already observed. We take into account relationships between independent drivers and health outcomes, whether it is some of these covariates or whether it is some of the risk factors like smoking, obesity, air pollution. And we also impose a number of regularities that we know from the past. So for instance, there's something called Gompert's law that past age 40 on a log scale mortality rates are almost invariably linear. So we don't want our forecast to start to deviate from what we've observed over many, many years in the past. So that all introduction, I'm going to show you a whole heap of different results. Let's start with this one, population. When we started doing this work, we soon realized that the habit that everyone in population health has of using the UN Population Division's population projections fall over. Basically, when you start doing forecasting, you magnify inconsistencies that you've made in your estimates, which with normal vetting procedures, when you make year-by-year estimates, you think, oh, this looks pretty good. Once you start projecting them forward, you can get massively wrong things or things that don't hang together. So if we look here in black is the projections from the UN Pop division of the global population. And you can see that we expect a much smaller growth in population. And as everything in the global burden of disease needs to hang together, it's very important that we make our own population estimates that are consistent with all the other assumptions we use on fertility and on mortality rates. Just on covariates, there's actually no long-term projection of GDP. World Bank, IMF, they make short-term projections. OECD makes longer-term projections, but only for the rich countries that are part of OECD. So we've tackled this, and we have a time series of better and worse and baseline scenarios of projected GDP. And what this shows is that in 2040, we expect a large part of the world to fall into what currently would be defined as high GDP countries, including China, including a whole lot of countries that currently are not in the high bracket, like Turkey, that would move up. And that the low income status countries would be almost solely restricted to Africa, with North Korea, Afghanistan, and Yemen being the exceptions. Also, the millions of people living below the almost $2 in 2011 purchasing power parity dollars of the poverty threshold will come down quite dramatically. And by 2040, we expect that more than 3/4 of people living in poverty will live in Africa. Large changes in GDP, both in absolute numbers of GDP or per capita. And you can see that the largest increase is in GDP per capita is expected to be in the upper middle income range, followed by the lower middle income range. But an acceleration also in low income in per capita terms. Then in 2040, 40% of the global population will live in countries designated as high income. A large shift, and that's not because those countries have a massive population increase, but it's because many more countries join the high income category. Education. These are our projections of the age standardized years of schooling in the population over age 15. And you can see large increases with some convergence between female and male rates, but still, even in 2040, a considerable gap. This is an index that we use a lot to indicate a country's level of socioeconomic development, and it's cobbled together from GDP, years of schooling, and a total fertility rate. This is the 2015 picture, and we can then look at how is this changing over time. And in this one, you can see that compared to 1990, the 2015 values of socioeconomic development has increased quite a lot. And we expect over the forecasting period to 2040, there almost to be a universal increase in those important socio-demographic factors that have a big bearing on health outcomes. Now, let's move on to some risk factors. These are our forecasts of smoking prevalence by males and females combined. In blue, the sort of trajectory of a reference case, but depending on what happens and what actions will be or will not be taken, it could be as optimistic as the fast decline in green, or the stagnation or slow increase overall in red. In China specifically, and you can see that there's uncertainty around these estimates. In relative terms, much greater uncertainty in women, but that's because the smoking prevalence figures in Chinese women are still very low. But it could, be on the increase. It could be on a decreasing trajectory. Blood pressure, similar sort of graphs where the long-term trajectory we think is for a decrease in females in this age category, but some tick up in males, but it could be coming down, it could be going up quite considerably. Global vaccine coverage scenarios, where here we've plotted what we think under different scenarios may be happening with vaccines for rotavirus, measles, pneumococcal vaccine, and the DTP3. And the next two slides indicate how we do this. So this is the overall projection of what will happen with diarrhea mortality. But we actually do that in two components. If we look here, and you can see how much lower the curve is on this log scale, this is the trajectory of the amount of diarrhea that we cannot explain by major risks like water, sanitation, hygiene, and a few others. So by separately projecting what if you like, the risk-deleted disease burden is, and on top of that projecting all these drivers of an outcome like diarrhea, we make use of all the information of past trends and come up with a composite picture of what we think is likely to happen. And there are big changes. If you look here at on the x-axis is the amount of change that we recorded from 1990 to 2015. On the y-axis is what we expect to happen in 2015 to 2040. And you can see there are some in the bad quadrant. Diabetes and chronic kidney disease, CKD, they have been going up over the last 25 years, and we project them to continue to increase over the forecasting period. But many other diseases are decreasing. Very large decreases in diarrhea, malaria, preterm complications, TB, despite what Gilla was saying. Yes, there is quite a considerable decline in TB, not by far not enough to reach the lofty targets that the TB community has set itself. But also, quite a bit of success in cardiovascular disease. You see the ischemic heart disease and stroke, big blue blobs in the middle. COPD, quite a bit of improvement. Lung cancer, because of changes in smoking. But Alzheimer, somewhere sitting at the null. In rate space, it's not going up a lot, but it's certainly also not decreasing. And if you combine it with all the demographic changes, that in numbers is the big, the one that's going to dominate the health loss in coming decades. HIV, different scenarios on what will happen with the coverage of antiretrovirals. And in a baseline, we expect it to continue to expand, but not as rapidly as when we started implementing ART. But it could be leveling off. Who knows? There's been a lot of money poured into HIV. How much of that will be sustainable? How much of that will continue to happen? Or it could continue on a much faster track. And then the consequences on new cases, mortality, and existing cases. Here, TB, an enormous decline since 1990, but as Gilla indicated, you would not, even if with our most optimistic scenario, reach the targets that have been set for TB internationally. Under 5, diarrhea, important cause of death. Under 5, lower respiratory infection, another major killer of kids. Cardiovascular, so there you see a divergence of potential trajectories. It could get much better still. There's been quite a large decline in death rates from cardiovascular disease. But again, how can we sustain that? And we make very widely diverging forecasts that could be possible under a pessimistic or an optimistic scenario. Diabetes, even in an optimistic scenario, in most age groups, we'd be very lucky if we keep stable rates. In the elderly, even under the most optimistic scenario, we still expect rates to be increasing. The massive increase in body weight is driving this, and it is happening almost everywhere in the world, although some countries are much better at it than others. And there are few places that have yet to go through the obesity epidemic. For instance, Vietnam, where even in the most recent years, you still have mean BMI values that are closely around 21, 22, 23, with narrow standard deviation and less than 1% of the population obese. They've always kept fast food chains out of the country, but they've recently reneged on this, and we'll see what happens. And it could have an explosive trajectory like you have seen in a neighboring country in Thailand, for instance. Cancer, death rates, females, if first males, then females. This is a map of the 1990 pneumonia death rates in under fives. In 2015, already quite an improvement. And look at what we think might be possible in 2040. This is in the baseline scenario. So we're forecasting major changes in some of the areas of burden of disease. Here you can see the trajectory, the aggregate trajectory by age, where we expect the larger amount of gain to come from younger age groups. The neonatal causes, then the mostly childhood infectious disease causes, and into adolescence. And with increasing age, the ability to turn around burden becomes less, because things are more dominated by long-term chronic conditions that are more difficult to intervene on. Life expectancy in 2040 compared to 2015. In both males and females, we forecast pretty large increases. In absolute terms, the largest at the lower end of the scale. But there are some countries that will struggle to see an increase in their life expectancy, or might actually drop a little over time. In China, all of these are illustrations of the sort of richness of the data that we're developing. Here is the annual rate of change in this graph for males at a global level. And you can see there's quite a varying picture here, with some diseases continuing to decline quite rapidly: ischemic heart disease, ischemic stroke, diarrheal diseases, diabetes being on the other side of the null, and a number of diseases that are somewhere in between. COPD, not a lot of change, depending on whether it is an optimistic scenario or not. A relatively similar sort of picture for females. Okay, that we had already. So just to sum up on this is just the beginning. We haven't, we're just creating this vehicle that we can then, over the next 10 years, exploit to build on all these what-if scenarios. And in consultation with policymakers, say, well, what are major decisions that you need to make? And then we'll see how we can build that through these forecasting scenarios and give more relevant information to policymakers than we've been able to do so far. Because as I said, the current global burden of disease is all water under the bridge. Things have happened already. If you want to look forward, this is going to be the most powerful vehicle. As a side effect of doing all of this, it's fantastic for us to vet what we are doing. Because with the forecasting, we are seeing what maybe at face value look like minor inconsistencies being blown out over time, and it really helps us to make better estimates of our regular set of estimates for the global burden of disease as well. So a first preview of where this is likely to go. You're going to hear a lot more over this in the next number of years. Thank you.
I'll start. So I had two questions. So when you talked about the data that you put into your model, at least from my interpretation of the types of data, it's wildly varying in quality. So how do you account for that in the model? Do you give different weights, or how do you even know what the weight should be?
Very good question. And I like to think of us as the ultimate skeptics. Whenever we get data, we don't believe it. We toss it up 10 times before we say, oh, well, we might be able to use this. We've become very good at detecting a number of common sources of bias. For instance, in all the information we have on causes of death, we do a massive amount of redistribution from what we call garbage codes to more meaningful codes for policy. We do the same for all the non-fatal data sources. Differences in methods on how people collect data, differences in case definitions. All these things create measurement noise. And where we know of these sources of measurement bias, we try to correct for them. And we have established methods to do that, but this is not easy, because you may know and get better at knowing what these sources of bias are, but there are quite a lot of sources that you just won't know about. And we need to develop further methods to deal with this, what we call residual measurement error. How much of variation that we are quantifying is true variation, how much of it is still bias that we were unable to correct for. But we're very much tuned into this because we're secondary data users, and so we have to deal with all these variations.
Theo, I can understand how you can forecast the increasing disability or decreasing disability through GDP per capita and fertility rates and climate change and possibly obesity through McDonald's and so on. But we're going through a microcosm of time where there are three structural revolutions going on. One is biomedical, the second is information technology, both software and hardware, and the third one is social media and social sciences. So my question is, how can you predict the innovations that are going to happen up to 2040 to be sure that you can be right in these predictions? Or are your graphs suggesting that the variation is so big that you can't make that prediction?
Well, as you saw, the variation is pretty large for major disease outcomes. And so that means we're almost sure to be right because there's so much variation. But the whole point of this is not to accurately pinpoint what we think, what is going to happen, but to provide scenarios that we can build on and say, well, what if there's a massive new breakthrough, an HIV vaccine, or the cocktail of 4 new drugs for TB that Gila was talking about, or you name it, or much better understanding of how health systems work, and through artificial intelligence making much more informed decisions in healthcare that can vastly improve health outcomes, like we saw in the previous presentation, is potentially there. So I would see all those different influences as things that you can try to quantify through this platform, as long as you have data to support that quantification, of course.
So is the idea that as time goes on, when you see a new innovation, you'll change those graphs accordingly?
I think what we'll do is we'll keep this baseline scenario largely intact, but we'll build on these what-if scenarios of a large innovation in technology.
I just noticed for all the metrics you are using, there are some at the individual level, some at the regional, community, country. So I'm just wondering, have you used a multi-level model, treated them differently so that your residual, global residual will be minimized, or you just use single level?
Well, I'm not quite sure I understand, but all our analyses are at the most granular detail of location, and so it's all the countries and their subnational locations where we make those estimates, and we make separate estimates for the deaths, for the incidence and prevalence, but we try to look at how they hang together. Can you have this estimate of prevalence with this estimate of incidence and that estimate of the number of deaths? There's a logical relationship that has to exist between those.
But presumably some metrics you get into your equation are at a really very regional level. Some are very global, some are individualized.
Yeah. And so we
so
depend,
if you treat them equally, it's going to
well,
get
we
very
depend
different.
very much on what data are available. And as indicated, how do all these different data sources talk to each other? What's the quality of them? Should we give more weight to if it's measured this way or if it's measured that way? How much can we correct for systematic shifts up or down just because of how data have been collected?
Thank you.
Okay, first let's thank